Hi, I'm very excited to lead this community panel. We have really great community leaders with us today. We have Karlene Shugars from Center Drug and Alcohol. She's a program manager, but she's been at almost every level in terms of recovery and treatment support for Center County. We have Angela Simmons. She's a certified recovery specialist, and she has lots of experience, boots on the ground experience working with individuals with substance use disorders. We also have Dr. Amy Jessop from Prevention Point, a very internationally recognized harm reduction community-based program. They do a lot of great work on boots on the ground work for people who use opioids and other drugs. And then we have Chris Erthal, who's also a certified recovery specialist, but he's now the program director of the Nicholas Sober Living House. So again, lots of experience amongst all these four panelists. So we can just get started. If you all can just introduce yourselves, where you work, the client population you see, and just anything about just the work that you're doing right now.
Hi, my name's Angela. I'm a CRS, which is a certified recovery specialist. Basically, I have lived experience, which helps me to provide support to the population that I work with. I work for the Nicholas House. We provide residential recovery house to clients, and then we also have peer support. So we work in the behavioral health field. Population I work with, they suffer from trauma. They also, I guess, co-occurring mental health and substance use disorder. And I would say housing instability is a big thing, ongoing legal involvement. Many of my clients are navigating multiple systems at once while trying to rebuild their lives. So I'm there pretty much for support to help them with whatever they need.
And how long have you been a CRS or in that peer support role?
About 4 years.
Hi. Good morning. My name is Karlene Shugars. I am the program administrator for Center County Drug and Alcohol. I've been in the field for about 30 years now, which is scary to admit. I began work at the county as a case manager, moved up to program specialist, to case manager supervisor, to program administrator. So I pretty much worked at every level there. I would say 90 to 95% of the clients that we work with are from the criminal justice system. We do work with anyone in the community who comes to us seeking treatment, but still proportionally, most people are motivated by the criminal justice system. Our office is responsible for kind of measuring the pulse of what treatment and prevention services are needed in Center County, and then making sure that they're available to everyone. So we also provide funding for people who don't have insurance to go to either residential or outpatient care, whatever level of care is needed. We help underinsured and people who can't afford their copays or deductibles, just to make sure that anyone who wants to go to treatment can, and that the resources are available for them.
Hi, everyone. I'm Amy Jessop, and I am currently the Director of Research at Prevention Point, which is kind of a new role. I've been associated with Prevention Point for more than 20 years. I was on the board of directors before we created this research position. And so I've been part of the leadership there. I'll tell you about Prevention Point. It's not about me. So Prevention Point is very large and now multi-service harm reduction organization in Philadelphia. When I joined the board there decades ago, we had about 10 staff and a whole bunch of volunteers. We now have a staff of 139 people full-time, plus more part-time folks and tons of volunteers. And we, as I said, we're multi-service. We started as a syringe service program. We still maintain the syringe service program and other safe supply distribution, overdose prevention programs, and we train thousands of people a year for overdose prevention, distribution of naloxone, probably 100,000 doses a year. And we also now provide in-house medical care, some primary care. We do have an HIV clinic. We have a hepatitis C clinic. We have a wound care clinic. We have one of the largest PrEP programs, I think in the country, certainly in the state, with lots of women involved in the program, which is sort of unique as well. We also, like what else we do? We now have recently added therapy and counseling, and we have now an on-staff psych NP who's been very, very helpful as the needs in our community change. We also have a housing program. We have a shelter that is solely run by Prevention Point, we call Beacon House, with about 60 beds. And that was super important when we started it because the shelters in the community wouldn't accept people who were using drugs, or the rules of staying there made it kind of impossible as certainly as fentanyl became more prevalent, people couldn't come in and out. And then most recently, we partnered with the City of Philadelphia Office of Homeless Services and Project Home to open a new shelter. And Prevention Point operates about 90 beds there, and Project Home about 80. And we have Prevention Point provides medical services for all the residents in the building. And we offer full services from screening through medical case management. We also offer substance use treatment. So we have we call it our STEP program, and we offer buprenorphine, counseling, Suboxone, Sublocade. We have a very large Sublocade program now that's going really great. So yeah, we have lots going on. It's all the staff. And I'm thrilled to be here and talking to you all, learning about things and hoping that we can make some connections for more work at Prevention Point.
Hi, I'm Christopher Erthal. I'm the program manager with TNH Sober Living. TNH is a recovery house. It's actually the second largest in Pennsylvania. So we have 21 houses across 3 different counties. And a couple of years ago, to kind of like navigate the challenges in early recovery, we had just a revolving door of people coming out of treatment, coming out of jail, coming out of like the hospital, and that 2 to 4 week period where they're just like scrambling to get a job, scrambling to just like get a good footing and like build a foundation. And because a lot of times people are going to treatment, bouncing around, they're out of the area, it was just not like a really high success rate. So we opened a peer support program, and like we've seen really great, like a profound change in the success rates with like that added support, having a CRS to help them like navigate through those challenges, helping with job searching, transportation, connecting with like the local resources they might need. And that's kind of where we're at. We also have a recovery navigation program and a peer support program within one of the prisons, like the local prisons in Adams County.
Awesome. You mentioned your success rates. Can you all tell us how your organization defines treatment success and recovery?
Mm-hmm.
And if that definition has changed over the last 5 or 10 years?
Yeah.
And why?
You want to start?
Oh, yeah.
Yeah, I would say maybe even myself, like 5-10 years ago, success was very much abstinence-based. How long are you sober from all mood and mind altering substances? Whereas now, like our peer support program is looking at success of like, are they, financially stable and able to move out of the recovery house and get their own place? Like, are they achieving goals like finding employment, returning to college, and just like having stability in their lives? I would say a successful discharge from our peer support program would be them achieving like most or all of their goals, and them, deciding that they're ready to step down, because we leave it up to them. It's like a pretty long-term program. So, I mean, we've had clients that remained engaged in services for 2+ years just because they benefited from the added emotional support. Whereas the recovery house success would be more so monitored as more of just like moving out, giving notice, finding another place and moving on.
So you want a definition of recovery?
Yeah, recovery, treatment success, and how to change in the last 5 years.
Yeah.
And any success stories that you may have.
Yeah. I would say if none of you know where Prevention Point is located is in the Kensington neighborhood of Philadelphia. And you've probably seen video if you haven't been there of what things are like. So not all, but most, I would say, of our participants are either living on the street or one step from living on the street, have been using for a very long time. And so like we view success for our participants as being alive the next day. That's a huge piece. For those who do enter our substance use treatment program or a STEP program, somewhat like you were describing, we're often not seeking abstinence from all substances. It's again, keeping them alive, helping them move to be able to care for themselves, care for their friends, maybe get a job someday. So it's really, can we help people get on the road to some stability? And for those who do well, it's fabulous. We do have a telehealth program. So as people start doing better in our treatment program, kind of encourage them to do that so they're not coming to Kensington for care and walking past where they bought drugs and where their friends are and things like that. So that the telehealth program has been super successful. And our Suboxone program has been, not a Suboxone program, our Sublocade program. We primarily use Sublocade, and it's been life-changing for many of our, especially long-term clients. Our best success stories are those people who have been participants for a long time and they're able to recover at least into some stability, and we hire them back as staff. So we have a large segment of our staff who used to be participants and they're able to function and help people. We have many recovery specialists. Some of our directors of our programs are former participants. So those are our best success stories.
Well, as both of these folks mentioned, the definition of recovery in the early days was life abstaining from alcohol and drug use, no substance use at all, service to others, self-growth, self-assessment, and bettering your quality of life. Right now, the Substance Abuse and Mental Health Service Administration's, SAMHSA's, definition of recovery doesn't include the word abstinence, doesn't include the word drugs, doesn't include the word alcohol. It has nothing to do with abstinence. And another big shift is that recovery becomes something that is self-defined. So your goal may not be to get sober, it may be to cut down. If that's your recovery, that's your recovery. A lot of people in the field really struggle with that, particularly with medical marijuana now. In Pennsylvania, like sober living houses are not allowed to prohibit the use of medical marijuana. But the people who live there, a lot of them say, I don't want this, I'm triggered. That's going to trigger me. So it's been a struggle. And the successes we celebrate are any tiny little improvement, particularly in the criminal justice system. We have both a drug court and a DUI court, and an intensive case manager who staffs both of those. And at the beginning of the program, one of the requirements is that you call in every morning and see if you have to drug test that day. Well, the most common violation is that people forget to do that, or they don't do it for whatever reason. So, the first time you've got a client that makes it through a week without any misses, that's something to celebrate. That's something to acknowledge in court. It's a success. And I can't really argue with self-directed recovery because, as Chris said, I think it comes down to people being better off and more functional. Is your life better today than it was yesterday? And I will leave something for.
So adding to what these three have said, I would say to gauge success it's basically just with the individual, the client themselves. And once they set their goals, are they reaching their goals? Whether it's just small progress that they're making towards the goals that they set or actually accomplishing and moving forward. I feel like it has to be individualized. And I mean, when I first got sober, it was all just about abstinence and kind of cut and dry. But I've realized that recovery is definitely not linear.
Do you think kind of like your experience going through recovery impacts I mean, I don't say expectations, but kind of how you work with your clients in terms of what is recovery for them and
Mm-hmm. Well, I like you were talking about like treatment courts. I graduated from drug court. So of course somebody who is in drug court and then they have a CRS who has went through the same exact thing, they're going to trust. It's going to be easier for me to build a rapport because I have the experience that they're dealing with. So it's definitely easier for me, I would say, than somebody in a clinical position to gain somebody's trust and be able to give them the support because we build a rapport that's friendly and like safe.
So you had mentioned in your question about success stories. I just kind of wanted to share, like, kind of paint a picture of what it's like getting out of getting out of treatment. You're going to a recovery house. So like, and I've gone through this many times myself. You're starting over in a new city. You have no family support. You have no money. You have no car. You have no license. You owe recovery house rent, which is due in 2 weeks. You have to find a job within 7 to 14 days. You have to go to probation appointments. You probably have an IOP that's 3 to 4 days a week. The recovery house wants you to go to meetings 4 to 5 times a week. And you're trying to navigate all of these stressors. And I've seen, I have a client that he was just so angry. And in my mind, I was like, oh man, I don't know what I can do to help him. Like, I don't see this working out. And like little by little, he just really committed to setting goals and working towards his goals. And this individual went on to do SEP work and involved in AA, sponsors other men. He was the recovery house manager, started his own successful business. I have another example of a gentleman that actually had some medical issues and I just remember being in the hospital with him and he was so distraught over like, what am I going to do? I don't have a job. I'm not going to live around and be homeless. Like in that instance, we did actually work with him and now he is a recovery specialist and he's running our recovery center. So just seeing those are the stories that really like keep us going. That's all.
So when I started, I had this client, she came in and she was a victim of sexual abuse. And not only that, was coming off of drugs, and also navigating, she had to do IOP, she had to get a job and being able, I would say, all of that stuff, plus healing from trauma and having to have a surgery that was like reconstructive surgery. Just seeing her from who she was when she came, feeling totally depleted and broken, to then, I know that for me, I offered her as much support as possible if she needed to go. I mean, and it was kind of like doing things for myself, having like her schedule for everything she needed to get done with all these doctor's appointments and just helping her push through. I know when I got sober, I worked on my trauma. So it was really awesome to be taken full circle and be able to help this woman through all of her emotional trauma while healing, and then, getting this surgery done, being there. She had to get funding as well, get that set up. And that was just hoops to jump through, so many hoops to jump through till now she's working in recovery. And it's just amazing to see those types of stories. So those types of things happen from recovery.
Very inspiring. What are some notable barriers? Because you guys are doing amazing work, and even in this political climate, we would anticipate a lot of pushback, funding, anything. So what are you guys noticing?
I would say a huge one is transportation. I have a client who, she moved here from Harrisburg, or to York area from Harrisburg or Cumberland County. And she had a CYS case. She had visits that she was like, this was like the most important goal that she had, was to reunite with her son. And just finding funding for, or even just going to churches. I was trying to track down some kind of like voucher or Uber voucher for her. So transportation, I feel like, is a huge one. And because her visits with her son were an hour away. So of course that is going to be challenging. I ended up driving her a bunch of the times. I would say another one is housing and funding. People don't have jobs. And then it's hard for people in the criminal justice system to get a job in the first place when you have all these charges that hinder you from having a job that is going to pay. I mean, I had a client making $9 an hour. I can't even imagine how. Other than mental health is another big thing happening. It's like, it seems like, and I know we're not really here to talk about mental health, but it kind of goes hand in hand with addiction. And I feel like, I don't even know what to say. I just know that that's a barrier.
Please understand that I am not talking about the people who work in the treatment system, but the treatment system itself has largely moved from a nonprofit base to a corporate model. And now it's about profit. And if you want to keep your profits coming, you keep the door spinning. So places now are largely understaffed. That's a huge, huge problem. People can't get the length of treatment they need. There's a big push for getting people out as quick as you can, because we've got medication-assisted treatment, so they should be okay. And the other obstacle is just our society and our societal expectations. I mean, I think the people who I see do the best or have the greatest success rate in recovery are the ones who already have a foundation to come back to. They've been in the workforce, maybe they have a degree, they've got housing or family that can help them out. Most of the people that we work with, they've been using drugs since their early teen years. They've not been in the workforce. A lot of them haven't finished high school. They may have kids, but they don't know anything about parenting. You know, their parents have been raising their children. And we put them in 4 weeks of treatment, during which time they're going through severe post-acute withdrawal. And we hit them with, okay, you know, here's some Reiki, here's some yoga, here's some acupuncture, here's some musical therapy, here's some art therapy. And their brains are too scrambled to take anything in. And then they're supposed to come out and start living in the world. Well, as Angela was saying, they can't get jobs, or the jobs they do get are minimum wage. There was a housing study in Center County that determined if you were working for $10 an hour, you would need to work 75 hours a week just to cover your rent. That's nothing else, just your rent. So, and people tend to say, well, but there's help, there's help. Help is short term. You know, we do offer intensive case management to our clients. We may be able to find them a place to live by paying for their security deposit and their rent. We may be able to help them find a job. But when the supports are taken away, most of them find they can't afford their rent. They're not making enough money to take care of their kids or their families. You need hope to remain in recovery. And that involves being able to build a better life, not just willing. But when the resources aren't there, it can be devastating. And we see a lot of the same people going through the same cycle, coming through again and again, because they can't get their footing in the world.
Yes to all of those things. So I will add that housing, I'm going to reemphasize housing. When we do get people into care, into treatment, and they start getting some stability in their life, they often have nowhere to live. Or they can live short term on this person's sofa, that person's sofa. It's really difficult. And that housing, lack of housing impacts every single thing about their recovery, impacts every single thing about their ability to really start becoming a productive citizen. And we have, you know, in our shelters, when we do get folks into treatment, especially inpatient treatment, you know, they come out and we find them again on the street, and then they're not a priority to get back into the housing or our shelters because they've already been there and kind of left. So people sometimes don't want to go to inpatient treatment because they know when they leave, they don't have their shelter beds anymore. So they remain in the shelter, they remain using, because that unknown of what's coming later is too great for them to manage. And I would say that for Prevention Point right now, and for the city of Philadelphia, political change, change in acceptance, change in approach to how to deal with how to address the issues of both homelessness and substance use in the city. It's a 180-degree turn from what had been. And in some ways that's maybe helpful, but in many other ways it's been dangerous. People are afraid to show up at centers where they can get support, because next to the place where they usually got support are 20 police officers looking to pick people up and take them to our new wellness court. And there really just isn't a humane approach to some of that. So that has been a big thing. So we're seeing people isolate themselves, not apply for benefits that they may apply for, not try to enter treatment because they're afraid of the legal justice system in particular. Many have outstanding bench warrants because they've been picked up by these 20 police officers, been giving a summons to show up at court, but they have no address. They don't know when they're supposed to show up. They don't have a calendar. They don't have a watch. And so then there's a warrant for their arrest. So they're very afraid to come forward and engage in any of these services that would help. They stay isolated, which makes the death from overdose more likely. And we still are seeing, I know there's been some talk this morning about the reduction in deaths from overdose, and that's definitely true even in our neighborhood. But I don't think the rates of overdose are going down. I think we're doing a much better job of keeping people alive if they overdose. And I get a little worried as people start saying we don't need as much attention to the overdose crisis. I think the reduction is showing that we have a good response and it's working, and I hate to see it go down. But, so overdose, I think, is a problem, but a lot of that stems from the citywide approach and I guess nationwide approach these days. We even took the words harm reduction off of our website. We were one of the first harm reduction organizations in the country. And just because we would like to participate in opportunities for federal funding, state funding, city funding, we're a prevention center now. And that's sort of, it's just a whole big change in approach and language and stigma. I'll leave it there. Thanks.
Yeah, I mean, I could echo pretty much what everyone else just said. I was just sitting here thinking kind of about my own personal story. And I was an individual that was in and out of treatment centers in probably 30 rehabs. I was in Kensington for, just spans of time of months, weeks, maybe even a year. And looking back at this last time and what really made my recovery stick is because of the length of time that I stayed in treatment and the length of time that I stayed in structured, sober living. So like I was in treatment for 5 months, followed by a year and a half in a recovery house. And I believe that we put so much emphasis on treatment and the actual rehab and getting sober in that aspect, but nobody's looking at the aftercare. And at some point, everybody has to get out. They got to get out of treatment at some point. And that's where it is going to either their recovery is going to take off or it's going to go just loop right back to treatment. So the biggest barriers, there's the mental health aspect. It seems like it's gotten a lot more severe. Severe mental illness has been on the rise. I don't know if this is related to maybe even some of the substances that are on the street or the trauma, but there's that aspect. Cost of living, as you guys all know, is just astronomical as it is. So just imagine being individuals starting over with nothing. It is not sustainable. So, I mean, I'm fortunate I work for a recovery house organization that does work with people. If you are coming and you don't have the funds to pay for an intake fee or your first week's rent, we will allow them time to find a job and then work out making a payment plan. And we look for funding that's available. Funding has been drying up. It's been dwindling and dwindling over the last year to the point where we're just about at the point where there's nothing left in New York. So, how do you tell someone that just got out of rehab that they have to pay rent in 2 to 4 weeks? Because we also want to prioritize allowing other individuals to have a chance. So if we just kept everyone not paying rent, the business would fail. Second of all, we would have people that would not have that chance to get in. But yeah, I would say finding employment, it's very difficult. You can find employment, but you're making 9, 10, 11 an hour. You're living paycheck to paycheck. And when you have nothing, no foundation, no stability, it is so easy to relapse. When you are I'm going to be homeless anyway. I don't have any money. I have it's just so easy to make that decision to relapse. Whereas if you have a foundation, you have support, you have a job, things are getting better in your life, you're more likely to maintain long-term sobriety.
Thank you. So the next question is, in what ways have your organizational needs changed over the last like 5 years or 10 years, or your client needs changed, if it has?
Yeah, I've only worked in recovery for the last 4 years, but I'm gonna pass the mic. Okay.
As Chris was just saying, what we're seeing with clients is that they present with increasingly complex needs. You know, they've got at least one co-occurring disorder. Most of them have had trauma. They're, you know, probably in childhood. And I think, I don't know where the push comes from, if it's government, but there has been such a push to legitimize the work we do that it is a huge administrative burden. And we're not doing what people need necessarily. So our case managers, who are typically bachelor's level graduates, usually recent graduates, they don't know much yet. You learn by experience when you're working with people with substance use disorders. And they're being asked now to screen for communicable disease, to screen for suicidality, to screen for social determinants of health, to screen for co-occurring disorders, which we always did. But the point is, it's one thing after another after another. They're to provide education on to everyone who comes in on MAT, the 3, available forms of MAT. They're supposed to talk about privacy laws, which is important. They're supposed to provide education on communicable diseases and educate people about testing and where they can get it. When you have somebody coming in because they want to go to detox or rehab, and it takes you 2.5 hours to get through your assessment, that's not right. They're not ready for that stuff. And by the same token, we do a lot of intensive case management, which is working with people on a more intensive basis to help them meet the needs they have apart from treatment. Well, the first time you meet with this person, you do a needs assessment, and then the state requires your SMART goals. So here's this person who may not be sober yet or may be very new in sobriety. And you've got to come up with, 4 or 5 different life-related goals that they want to work towards. And then list what steps they're going to do to get there. Again, they're not ready. And then your notes, the case manager's notes, are supposed to reflect with each visit what they did to further that goal plan, what they worked on specific to those goals. You go see a client and she's, bawling because her boyfriend kicked her in the head last night because he got drunk. You're not going to talk about SMART goals. They're constantly putting out fires, and that's what you do with people in early addiction. But it's been determined that we can't get paid to talk to people and be human. They don't pay anybody to be compassionate. Like, it has to be this clinical, goal-driven thing where the person's goal is maybe just to stay alive, like Amy said, or the most basic of things, to stay alive without using. So SMART goals have their place. Not going to say they don't. It's not an early recovery. They can shove them up their butt. And they've made life miserable for my case managers. And people don't stay in the field. Because believe it or not, we don't make much money. I mean, you start as a case manager, you're making maybe $1 more an hour than you could make at Sheets. So it can be very discouraging.
Yeah, I would say excellent staffing is a big, finding excellent staff members and more so keeping them, because it is so difficult. People do not get paid well in our environment. It's just kind of traumatizing to work with people, and the next day, and it's not an exaggeration, that you could see your client had overdosed and died on the steps of the building last night when you show up for work. And how many times can you experience that before you're like, for my own sanity, I've got to leave. So it is difficult to keep people and to keep them motivated and strong, given what you see every day, what you hear. You've talked about what people, what the clients of specifically our case managers, what they hear each day from these people. And it is not about their goals, their SMART goals, and the record keeping and all that. So that is probably the most difficult thing for us, is to keep excellent staff, just because it is difficult. For Prevention Point, I would say right now our biggest barrier is sort of that change in attitude towards harm reduction, change in call it government bureaucracy, and the goals that at least our city has for our area and for the people that we serve. Huge funding cuts. I think having timely information about what is happening on the street, like we have great information, anecdotal from people walking through the door, but to collect that and help distribute that through the city is difficult. And so having some of that information would be helpful. For our participants, I would say what was talked about earlier today about the polysubstances, whether you want to have a drug supply or use drugs that have multiple different components in them, you have no choice. It's what's there. And the medetomidine used to be xylazine was our biggest problem, and all of the problems that came from that with wounds. We have a huge increase in participants who are disabled, in wheelchairs, missing limbs from the xylazine problems. And that makes it very hard for them to get housing and for them to get jobs and for all of the reaching their SMART goals. But now we're seeing just medetomidine, which is a much stronger sedative and terrible withdrawal. So people just keep using and using more because the withdrawal is so terrible. So for them, for our participants, those barriers are that when they do have problems with these substances, there aren't enough people who know what to do to deal with them.
So I wasn't with TNH Sober Living 5 or 10 years ago, but I would imagine, as with all the other recovery houses back then, it was very abstinence-based. It was very tough, very much like AA, NA centered. You get a sponsor, you get a home group, you stay sober from all mood and mind altering substances. There is no MAT. There is no, in some cases, people were against psych meds, unfortunately. And today we've definitely shifted. I know within our company, we have been much more accepting of MAT. We accept methadone. We accept, Sublocade, Suboxone. And I would say peer support like has changed a lot. 10 years ago, nobody knew what that was. Nobody knew the value of that. I think the value really comes from you're getting to that recovery house and you're meeting with your CRS, like Angie, and she's been where you're at. So she's gonna be like, all right, this is the plan. Like we need to get you into therapy. You got to do this for probation. You're going to need to find a job. Do you have a resume? No, let's get that started right now so you can get some applications out. And like, 5 years ago, even peer support was very new and underutilized. Whereas today, like the value speaks for itself. Like it is something that is being more and more integrated. And I would say within TNH, we have kind of shifted our mindset as well. Whereas before, you relapsed, you left the recovery house, period, end of story. Now it's like, okay, let's see if we can get them enrolled in peer support, bring them back. They can be discharged from the recovery, leave the recovery house, whatever the case may be. And like, that doesn't disqualify them from having their CRS. Their CRS will stay with them wherever they go. We've had clients in our program that relapse, come back, relapse, go somewhere else, come back. But like the coolest part about our job is when they call us and they're like, hey, like I'm back and I'm safe and like I want to meet up again. And that's really what we hope to accomplish is that, letting them know that we're someone that will be there for them, like regardless of what happens within their like traditional sobriety. But as far as kind of like what is happening across all areas, the polysubstance use is like nothing I've seen before. Before, your heroin addicts did heroin and your cocaine users did cocaine, and now everybody does everything, and everything has fentanyl in it except for the fentanyl. The fentanyl has medetomidine, xylazine, and it's just so much more intense. The detox is so intense that you cannot just go to a 30-day rehab and be okay. Like I know I was a hot mess, like into month 2 or 3. Like if I would have been put out into like a recovery house setting and asked to find a job, like I was not well. I was not ready for that level. So I think we need longer lengths of stay. We need recovery housing that's like not focused on just go get a job. I mean, you can't do job search work full time and also put the amount of time you need to in your recovery. It's just not possible. Like you got to ease people into it and you got to give people grace.
I absolutely. Yeah. It's a little off track, but another thing that complicates recovery for a lot of people is the legal high industry. All the gas station highs, all the substances that you can buy at corner markets, convenience stores, at gas stations that can be incredibly dangerous, can be addictive, can be fatal. Even here in Center County, we have had fatal overdoses from kratom. And people just assume, well, they must be safe. And, they're marketed as dietary supplements because dietary supplements are not regulated by the FDA. So when they test these products, 65% of the time, they don't even have the substances in them that they say they do. And we have lost quite a few people to synthetic cannabinoids, the fake weed, incense. You can use that once and get a brain bleed and die. So much more dangerous than marijuana. But everybody's constantly looking for something that's not going to show up in a drug test or something that's safe to help them maybe get off of opioids or methamphetamine. And again, it's a profit-driven industry. They have the next drug on deck before the one that's out there gets put on the controlled substances list. You can't keep up.
So give it, yes, what I said?
I feel like the one thing that's changed a lot is just medical marijuana. When I started, when I mean, using and going in and out of rehabs, that there wasn't like it wasn't medical marijuana wasn't a thing. So navigating that, I've seen it help certain people, and that's where I feel like it's like we said earlier, recovery is so individualized. You kind of have to be very open-minded to feel like, okay, this works for that person, this doesn't work for this person. I think that with the recovery houses where they allow it, and the people that are going to those houses, they know, well, this is a place I can smoke at or use medical marijuana at. And then other houses, they are not allowed to do it in the house or on the grounds, but if they have their card, as long as they have their card, they can. So that was something that definitely is different once from when I started in recovery.
So given all of the barriers and complications you guys have shared, what are some ways maybe researchers can kind of help in those directions? Like what research questions could be asked or can be looked at that the answers might help in like just a real world boots on the ground, like working with individuals with substance use disorders?
So I had wrote some questions. So what impact would a 60 or 90-day housing stabilization program where rent and basic needs are covered have on treatment retention and relapse rates? Then what are the most effective integrated care models for individuals with co-occurring disorders involved in the criminal justice system? How can trauma-informed care be more effectively implemented in early recovery stages? And what long-term support structures lead to sustained recovery beyond initial treatment?
Excellent. Yes. Just send it to the listserv.
Yeah.
Yeah, she got it covered. Not exactly a question, but one thing that I think needs to be looked into is the effects of childhood trauma on individuals' chances of maintaining long-term recovery. Because the people we see struggle most are the people who have experienced 3 or more traumatic episodes, like loss of a caregiver, sexual abuse or physical abuse, early substance use as a coping mechanism. They may do well for a long period of time even, but there always seems to be something that triggers and they go back. So if we could find more effective ways of helping those people, that would make me happy.
Excellent.
I have 1,000 questions, but I would say I'm going to sort of throw back to the group to say that what I'll speak for myself, but also for my organization, is that the research takes so long. And as we were talking about this morning, things change fast. And so, I was an academic researcher for a long time, and I know what takes so long. You see a problem, you learn about the problem, you write a grant proposal, you wait for your reviews, you resubmit that, then you get your money, and then you go out. You got to go through the IRB and then change all of those things. Then you show up on site to do some community-based work, and the problem is different. And so a large part of what I do every day is turn researchers away. It's like, that's not a problem here anymore. Or you just need a whole different approach. That's not what's going on. And they'll be like, but we have this huge grant. And I'm like, you're not going to find someone who's just using cocaine at Prevention Point or just using an opioid, there's no point in starting. So I think figuring out ways to move from, oh, there is an issue, to learning about it in a controlled and valid and reliable way needs to shorten, or so much of the work is not that helpful anymore. So that is a big one. And then also back to you guys, improving understanding of the researchers about the lives of the people they're researching. So that's the other reason that I send folks away. Like, yeah, that's not going to work. Nope, that's just, or what seems ethical even to an IRB board is not when you bring it into the community. Like, you're doing this and that is going to increase somebody's vulnerability for law enforcement engagement. It's someone who wanted to put GPS trackers on people's bodies for 2 months and see where they go. And if they have an overdose, where are they and who were they with? Were they with other people who had trackers? And this was approved by a federal agency. This was approved by their institution's IRB. And, when they brought it to us, I'm like, do you realize how dangerous this is for someone who's dealing with a drug dealer? Do you understand how dehumanizing this is? And their response is, we will pay them to wear them. And so it's not unethical. So I think having researchers, I had a PCORI engagement grant to bring researchers in and have them stay in our building for a while and meet people and talk to them and understand how they view researchers. They'll say, here comes the researchers to research on us again. And that's what the staff thinks as well. People come in, they do the thing that they want that helps them and often their career, not so much the people, and they go away. So I think looking to you all to kind of think of new approaches as you do your community engaged research, and to really include the places and the people better in your planning so that we get information whenever we see evidence-based practice. I'm always looking at the methods that led to that evidence and thinking, yeah, of course, for the people that could participate in that study, that probably works fine. But for 90% of the other people, it probably is not relevant or valid. So yeah, so I'm throwing it back to you. And I'd love to talk to anyone who is interested in talking more about those issues.
So within TNH Sober Living, we have two major counties that we are located, Lancaster and York. York has an office with, a peer support program that we have, individual sessions, groups. We have about 9 or 10 CRS, CPS, that's certified recovery specialists, and peer specialists, more mental health focused. And then Lancaster doesn't have that. And then I would really like to even start looking at the rates of engagement, long-term success. Sometimes it's hard to track. We know how well what's going on with within the clients in our program, but the people that leave that are not enrolled, it's hard to know. But one barrier I did forget to mention was medical assistance transfers, because everyone is coming from a different area. They went, they're from Allentown, but they went to rehab in Bucks County and now they're in Lancaster County. By the time their medical assistance transfers to our county, which we can accept for services, they cannot enroll. So that's a big barrier that I wish we could figure out a way to overcome. And then another one is just how to peer support, the measuring the efficacy of it, versus traditional counseling. Because I just see it on firsthand now. I'm obviously biased and people aren't going to tell me hey, I prefer my therapist and I think you're not that great. But they say, I would have never been able to stay sober if it wasn't for you guys, or Angie helping me, or my CRS never stopping believing me. I don't think I'd be where I'm at today. And I think peer support is something that is underutilized. So I would be interested in seeing how all of that kind of, plays out, but also the housing, that's the biggest one. Measuring how the success rate of someone maintaining long-term sobriety, however you want to measure that, with having access to a 60-day housing grant versus not. So they can focus on the recovery. They can maybe just get a part-time job and go to meetings and get involved with like the community, build that support network, because none of it's going to matter if they, if they don't have that, and like they'll have a job, but if they're going to relapse, they're going to lose the job. They're going to be back in a rehab within a few days after the relapse. So it's just, yeah, I think the key to individuals sustaining long-term sobriety is building that foundation and believing in themselves. And part of that is like building that stability.
Awesome. And the last question before we ask audience questions is, in what ways can researchers collaborate with the organization now? Like, do you guys look for collaboration with researchers? Or ways they can partner with you all?
Yeah. I'll start since that's what I do all day. So we formed called a research department. It's just three of us. At Prevention Point, when I was on the board, we started as just having a group of us who could triage the dozens and dozens of researchers who come monthly wanting to do research on us at Prevention Point. And we welcome research. We need knowledge. We want it. We would have 12 people come with the same, wanting to work on the same issue, and that just wasn't possible. So we had to sort of triage which ones do we choose, and then also look at the ethics and how would the work impact our work, right? So if you want to come in and you want to use space that's private to talk with people, well, that takes a private room away from our case managers and our doctors and stuff. So I think that, so we worked on a lot of those issues, and that's been helpful. And then I was able to get funding to just like start a center to do some of our own work. So we do the two things. We sort of triage requests that come in. We try to do collaborations with researchers, mostly for research that we think would be really beneficial either to us at Prevention Point, our participants, or the harm reduction community at large. And then we have our own questions that we've been asking over the years, and no one has sort of come through wanting to ask those. So that's what my group does. And so for us, like, we welcome anyone who wants to come and work with us. I will say our work has been impacted great. Our research collaboration have been impacted greatly in the last 3 years, because we are required to work with the Philadelphia Department of Public Health's Institutional Review Board. So all research that happens with our participants at our building, if I did a study in California, since I work at Prevention Point, I would have to go through the city's IRB. And it's way more cumbersome than, I was an IRB chair once, and this process is way more than it needs to be. So that really delays work, especially student work. But we still welcome it. And if it's great work, we'd love to collaborate with you and just be ready to hear how will that work impact the organization that you're trying to collaborate with. And yeah, thanks.
Collaboration with the community. Collaborate with the addicts and the drug users. Not to burst anyone's bubble, but a lot of researchers and academics are not real familiar with drug and alcohol subculture. You want addicts to complete your survey? Have an addict help you write it so that they put it in language that people know what they're talking about. And they're trusted. They're from the community. They're trusted. And also, not saying, again, not all, but some academics are really quick to discard anything that doesn't have data behind it. You talk to people who have worked in the field for 10, 20, 30 years, they've observed a lot. They've observed a lot of patterns, A lot of what the problems are with the treatments that we're using, what works for people, what doesn't work for people. So yeah, actually, if you're going to collaborate with people from the addiction community, pay them to come in and help you carry out your study.
Yeah, I agree with what she said. I would say collaboration with peer support specialists and researchers would look like the researchers observing the service delivery. And I would say um, it would be also very important for the researchers to report back and follow up with the organization and the staff members with their findings so that they could adapt or adjust, to what would help the client.
I can add one other thing is measurement tools would be great. So many of the things we talked about here, people talk about there's no way to measure the impact of those things, no way to measure if they happened or how much did they happen. Development of good measurement tools for the field, I think, would be super.
I feel like when I think of research, I'm thinking it in like a clinical, in-office kind of way, which can be kind of cold and ineffective sometimes. I think a lot of the biggest breakthrough moments that I've had working with clients are like out in the community, out in the real world, like being with them and like celebrating them having their charges dismissed and them not going to prison and being in the courtroom, or like being with them when they accept that job interview, that job offer. Yeah, we've never worked with any researchers. I mean, we are a recovery house organization. We've been around for quite some time, but we've just recently started expanding into peer support about 3 or 4 years ago. So we would be really open to any kind of research collaboration.
Yeah, awesome. So I'll open up to the floor. Any audience members have questions for the panel?
Hi, I'm Ray. So I work with students as the drug and alcohol focused counselor at one of the Penn State campuses. I've been working drug and alcohol for approximately 8 years, give or take, right? So I'm not saying I've seen everything, but like I've seen the movie, I've seen the patterns, I've seen what happens. I meet with a lot of students, and a lot of them are still relatively young, right? Somewhere between like 18 and like 23. So still early in life, right? But I see the pattern starting, and that's why I got the job there. So my question to you is like, how do I get them in contact with you? Because like I still have a lane to stay in, right? And I see the need that they have, but I don't know how to get them to you without overstepping my own boundaries, right? So I see what prevention and postvention can do, how important it is to the process. So is there a way that I can get students set up with like case managers? Not one of the complexities, I realize I'm rambling, but one of the complexities that a lot of the students that I work with are also here on visas, or their families are fortunate enough to make enough money where they have insurance, but the students don't have their own. So like, how can I get over that barrier where like they know they need help, they want help, but they're trying to do it while still maintaining some anonymity in a sense? So I don't know if you have any recommendations.
I would say depending on like how severe the substance use is, if it's something that's like early on, a big part of it could just be building a healthy support network and like finding their tribe and like finding people that are like-minded, sober individuals, like through NA, AA, Dharma, other recovery pathways. But within this local area, I wouldn't know the specifics, but sometimes there's like recovery centers where there's information that is available. That's always a good place to start. Like I would say almost every large town or city has some sort of recovery center where they do have information available.
They did recovery. recovery.
Yeah, it's hard to remain anonymous yet have services that get paid for by someone. And I don't know how to do that. So I'm gonna pass it on.
Yes, that is very difficult. Well, and it depends on who is collecting data or information from us. Sometimes we are able to remove the names, and just assign numbers so the person remains anonymous. But whatever supports you're looking for, every county has what's called a single county authority. And that's what my position is. They may not be able to help you, but they should be able to direct you to where you can get help.
Yeah, I would say to reach out to those support groups. There's always support groups. Depending on the level of care that's needed.
There's usually collegiate recovery services, and there's one, I think, in Penn State. Do you know about that? Oh, oh, okay. Yeah, collegiate recovery services.
Hi, I'm Janet. I was wondering, I'm in the prevention world, and I feel like we don't interface with you folks in treatment and recovery as much as we should. And I wondered, from where you sit, in that space of harm reduction and treatment and recovery, what would you like to see from those of us in prevention?
You were kind of quiet, so they didn't get to hear you. Do you mind repeating a little louder?
I think that's the first time anyone ever said I wasn't loud enough. I'm sorry, I'll ask again. So I'm in the prevention field, and I feel like prevention is disconnected sometimes from treatment and harm reduction and recovery, even though they really should be sort of a continuum of care, right? And so my question is, what would you folks in that space of treatment, recovery, and harm reduction like to see from us in the prevention world?
In Center County, we do work very closely with our prevention providers. It's constantly evolving. I mean, our prevention providers mostly work with youth, but now our office is expanding to offer adult prevention services that we'll be providing, particularly with gambling and the casino opening up. But yeah, always collaboration and connection is essential. One hand has to know what the other's doing. Demand it.
Yeah, I'm not too familiar with like prevention, or like even early prevention, but I would say like the Just Say No campaign, like that's all like kind of failed. Like the where they had the police officers come in, the scare tactics. Like I would say what dare. Yeah, I feel like that was kind of a failure. Maybe we can all could probably acknowledge that. But I don't know. I would say as far as prevention, maybe getting out of this mindset of telling young individuals that they have a progressive fatal disease that's going to continue to get worse. And like, that's kind of like a self-fulfilling prophecy. Like if you tell someone that, I almost feel like, they're going to make that come true. Just like trying to identify these younger individuals that are suffering from mental health, and get so many young people go through like really serious mental illness and they don't even get that diagnosed or treated until like a much later age. And I really think that that plays a big part in people getting into substances. That's all.
Chris said to me here, well, like, what does she mean by prevention? What are prevention services? And I was like, well, I'm not sure what she's talking about. And he said, well, you're from Prevention Point. I said, no. And I have to say I don't. So, often when we're involved, people are already like, so I guess I don't know what prevention services I was going to just talk, but like if it are services or programs to prevent use in the first place, is that what we're talking about?
Just seeing the client population you guys have, if knowing their stories, if there's any kind of services or any kind of interventions that could have been done prior to their substance use, what would that be? Or what could we work on?
As a mother to a 17-year-old, I showed my son videos of Kensington, and it prevented him from wanting to be on drugs. I know it sounds kind of extreme, but it seems to have worked.
It does start with kids, teaching kids conflict resolution, teaching them how to build relationships with other people. I mean, of course, drug and alcohol education is a part of it, but the bigger part is just giving kids the confidence to stand with other kids and say, nah, we don't want that. And I think to some degree that has happened. Like, my daughter's 25. She and her friends don't party like my generation partied. They're much more responsible, much more careful. So anything that creates the skills to refuse until your brain is more developed anyway is going to impact substance use disorders significantly.
I was, as everyone was talking, I was thinking again about that, bring people who are using drugs or have had a substance use disorder together with the prevention folks to see where along a path of their life, something changed, or has it always been this way? But most of the people that we see, you can lead back to poor conflict resolution skills for just some trauma, that occurred in their life that they're trying to figure out how to deal with. So I think, like you said, mental health services for us, housing is a big thing. If I'm living on the street or living in my car, I want to dull this experience, and it gets started. But
Yeah, I just wanted to quickly add on. I would say, when I was growing up, culturally, within music, within movies and everything, drugs were kind of glamorized in a way. Like the popular kid in school was the one that was going to the parties. You know what I mean? Maybe doing some cocaine. Trying to shift away from that. And really just identifying these mental health struggles early on. Because if I wasn't a depressed, socially anxious kid, I don't know that I would have done. I don't know that I would have taken to heroin the way that I did. It offered me this relief that I might not have had if I was properly treated for my anxiety. Yeah, that's all.
Maybe two more, and then we can always ask more in the during the lunch session.
I just wanted to thank you all and say kudos to the work that you do. I worked at Gaudenzia in the Philadelphia area, and at the turn of the century, I like to say, right in the beginning of 2000. And what has carried me through and why I have transitioned to working at the University of Pennsylvania State University, not the University of Pennsylvania, is meaning and what is meaningful. And that is something that is unique to each individual that we work with. I find it to be kind of easier to comb out what is meaningful with the students I work with, because part and parcel, they are Penn State students. But meaning is inherent in everyone. You said it with and you said it with motherhood. You said it with also with motherhood. You said it with working with Kensington. You said it with your daily life. All right. So I think as the slogan says, right, keeping it simple, and with the managed care and the SMART goals, right? It's almost, I started out a special ed major in undergrad. I look at it as like an IEP, these SMART goals, right? Whereas the grading system is 100 to whatever, 70 is passing. And IEP is a goal, right? And Susie didn't throw her chair through the window today. That's they won. So congratulations. I appreciate it. There's a lot more, but I'm going to pass off.
Hi, I'm Louisa. Thank you very much for your contributions. It's been really fascinating. So I'm more on the prevention sort of population end with Janet, and I was just, you mentioned trauma quite a bit, which obviously is a major problem. And I'm just wondering, I don't know that much about trauma care and trauma-informed care in Pennsylvania. And I was just wondering if you could talk a bit more about what Pennsylvania is good at and what it isn't from your perspectives in terms of dealing with trauma, especially childhood trauma, as people transition into substance use as they become young adults. Yeah, just anything you had to say about that would be interesting.
What Pennsylvania considers trauma-informed care is having a staff that acknowledges that trauma is a part. You know, trauma competent goes a little deeper as far as recognizing how people can be affected by the environment. You know, what's your waiting room like? What are your interview rooms like? And having resources to offer the person, or having a long enough relationship with them that they start to disclose that stuff. Because a lot of times, you know, we do assessment and referral. First time you see somebody, they don't want to tell you their abuse history. We ask about it. They don't trust us. They don't know us. So, yeah, building those connections, being aware beyond the fact that, oh yeah, that impacts sobriety. You know, how does it impact sobriety? What are the triggers with people who have trauma? Different for men and women, you know. Getting to know people, paying attention, research.
Yeah, trauma is, one of those words that gets thrown around a lot, but sometimes we don't really know what that looks like. I'll just say what, from my point of view, trauma therapy is very inaccessible and it's not really recommended to most people early in recovery. A lot of times it is get stabilized, go to see a traditional therapist for 6 months to a year, get some long-term sobriety, and then you can get into like trauma therapy. It could be like EMDR. Seeing in trauma therapists, it is very rare that people make it to that point, unfortunately. So, some of the things that we do in our program is just like have a group, Angie, like learning to live with trauma, learning to identify coping skills, like even that, just like learning to manage like living with trauma. Obviously, we're not doing trauma therapy. We're not claiming to be healing people from the trauma, but like just learning how to navigate living with trauma is like something that's pretty important. But I mean, I would love to see it become more accessible earlier on because of like the high correlation between trauma and substance use disorder, and even exploring alternatives like ketamine treatment is known to be super effective. But yeah, at trauma therapy as it stands today is not something that's very accessible to people in substance in addiction, I would say.
So she said the trauma informed. When I like started working with my caseload, I have a lot of women, and I realized that all these women have experienced trauma. So as long as it was like my scope of practice, I was able to start trauma informed psychoeducational groups with them where we I teach, just they're learning about the nervous system and regulating their nervous system back to like coming back into their parasympathetic nervous system. And then we learn, I teach them different somatic exercises, and we would go over family trauma and different roles in the family that you take on, and that you don't really want to just have that identity for the rest of your life. Then we talk about the different traumas when you're even just using drugs. But we went through the whole entire body, and we just work as a group on releasing different ways and tools that they can use to release the trauma from their body and regulate them back to a calm, so their nervous system is regulated.
Well, great. Well, maybe we can follow up after. I think we're sort of just over. I want to thank our panel. Thank you to Abby for organizing and moderating such an excellent panel. Thank you to each one of our panelists for your insights, and really appreciate your participation. Maybe an even bigger thank you for just all of the work that you do. So maybe a round of applause for our wonderful panel. All right, so next up, please everyone join us out in the through the double doors for lunch. And our next session will be our 1 o'clock poster session, sort of across the hallway. And find time to chat. Certainly come up and chat with any of our panelists, and we'll see you all back at 1.